Check one, two, check one, two.
Nasia, can you hear us?
I can hear you now. Cynthia, do you have my slides?
I do, but I think you can you sh I think you need to share on your end. Do you want me to forward them to you?
The problem is I cannot open them today. I'm not sure why my computer gives me headache. I can open them. I can download them, but I cannot open them. So I'm just
I,
sorry about that.
that's no worries. Do you want us to share them and then move?
If you can share them, then I can talk over them and then maybe I can ask someone to move it forward as I'm speaking. I'm so sorry. I'm not sure why is it happening. Usually it's never a problem. The Microsoft doesn't want to open up.
Recording in progress. Yes, worn down. And the complications of diabetes are everything because everything has a blood supply. So it's the leading cause of blindness under the age of 40 because your eyes have a very, very small.
What is this?
Remember when you went skating when you were little, and then you came back inside, skates off, and your feet were so frozen, and when they thawed out, they had that tingling in them. That's what neuropathy feels like. But imagine that times 10, like lots of pain, like it hurts actually when they thaw out. Nephropathy, disease of the kidney, cardiomyopathy, because your heart has a blood supply, hypertension, low sugars, decreased quality of life, neuropathy, gastroparesis, high cholesterol, erectile dysfunction, depression, amputation, stigma, and then the ultimate complication would be death. So you can see that diabetes causes all of these things for everyone, and it's sometimes it happens in a couple decades, sometimes it happens in 1 decade, sometimes it happens in 5 decades, but there's usually a smattering of these things with all diagnoses. And so why is the kidney so involved? Well, it tries to remove that excess glucose that's not inside the cell because you're not having enough insulin or no insulin through the urine. And so you lose the fluid, you drink more, and the cycle continues.
All right. Thank you so much. Sorry for the technical difficulties. I think we're going to be able to get started. We're just going to share the slides. And then Nazia, are you still on?
I'm here. Yeah, I'm here. Sorry.
No worries, no worries. So we're just gonna upload the slides for you and let you know. And then maybe in the meantime, I'll introduce you. So Dr. Selzner is a very illustrious professor of medicine at the Toronto General Hospital. She's the medical director for the Living Donor Liver Transplant Program. And she is actually also one half of a duo of Selzners, actually, at Toronto General Hospital. Um, she is the medical director, and then her husband is on the surgical side, is the surgical director for liver transplant. So sometimes people will come into clinic and be like, "Oh, I saw Dr. Selzner," and I'll be like, "Which one?" Um, so she is very senior. She's very knowledgeable about live donor liver transplant. She'll be telling you guys about live donor liver transplantation, and then she'll be available to ask any questions. Maybe we'll just give ourselves one more minute. Hopefully, the slides are going to appear very, very shortly.
There we
Perfect.
go.
Looks great.
Perfect. So thank you, Cynthia, for this very kind invitation, but also very kind introduction. And I'm totally sorry I'm not with you guys and being able to give this talk in person because, as you see, I'm wearing my white coat and I'm actually on call this week. But anyhow, the goal is to talk about living liver donation and transplantation. So if you can move the slide, sorry about that. Next slide.
Yeah, just a minute, sorry.
Sorry. Oops. Okay, well, maybe I can talk about so basically, oh, there we go. Are we are not sharing yet, no?
I'm not able to share it with full screen, so this will have to do.
Oh, that's all. Oh, okay, that's okay. So basically, the transplant program in Toronto is called, as you know, Ajmera Transplant Program, and this is the largest liver transplant program in Canada, and one of the largest in North America in general. So we have now done 4,000 roughly adult liver transplants since the program started in 1985. And over 1,350 of these transplants were from living liver donation. And we started that program in 2000. So this year was our 25 years anniversary, and we are just entering the 26 years of living donation. And just last year, we have done 80 only living donor liver transplant program. So transplantation. So you can see that it's a very robust program that has been around for many, many, many years. Next slide. So when someone is put on the waiting list for transplant, there is two options for them to receive a transplant. A traditional option or route is the deceased organ donation, and to get a transplant anyhow, everyone has to go on the waiting list for transplant. And if there is someone who passed away and their organ is available, they are eligible to receive those organs from deceased donors. But we also have the option of living donation, meaning someone who is otherwise healthy and anatomically suitable can come forward and donate to any recipient. They have to go through some testing, but we would be able to offer this option. And the reason this option exists is simply because there is not enough cadaveric organ or organs from people who passed away for everyone who needs a transplant. Next slide. So I talked about deceased organ donation, meaning people who passed away. They die and there are signed before before passing away to be an organ donor. And usually those organ is allocated based on a score that is called MELD score. And this score is calculated from blood work. So it's very objective. It's not that I can increase or decrease someone's score. I have to use their blood work, calculate the score, and that score is called MELD or MELD sodium. And the higher someone's score is, the more likelihood they have to attract the organ from a cadaveric pool of donors. And then these organs are allocated, so based on the MELD score and also based on the blood group of a recipient and their body size. Next slide. And this is the score or MELD or sodium MELD score is calculated. It's indicative of how severe is someone's liver disease. And as I mentioned, is very objective. It's calculated based on blood work. So there are 4 parameters from the blood work that goes into a formula, and those are the bilirubin, creatinine, which measure function of the kidney, INR, which is a measure of the ability of the liver to synthesize the clotting factor, and then the sodium concentration, serum sodium concentration. And these 4 parameters goes into a formula, and it gives us a number that is as low as 8 or as high as 50. And then at around 50, the number plateaus and would not go up further. So someone who has a MELD score of 30 or 32 or 35, they have more chance or more occasion to attract a disease donor organ compared to someone who has a sodium MELD of 15, 16, 17, or even in the early 20s. Next. Or low 20s. Next slide. You are going backward. Yes. So living organ donation is really a common treatment for liver failure in many parts of the world. In fact, in many countries in Asia, for example, Japan, Taiwan, South Korea, etc., most of over 2/3 of organ transplantations are done only through living donation. Because the cadaveric donation does not exist, or is the the rate of it is very rare due to their beliefs and cultural beliefs. And in India, for example, 80% of transplantations are done through living donation. So it's not something unusual. And in Toronto, as I mentioned earlier, we are one of the leaders in living liver donation and transplantation, and we represent roughly about 30 to 35% of all the liver transplants that we are performing in Toronto. Next slide. This is our program. I said that living donation started in year 2000. We are now, as of last year, 2024. You can see that our program has grown. Our number increases every year. The blue side in each of these sticks represent the number of cadaveric donor transplants. The red part, the living donor transplant. And you can see that every year, the number of living organ donation that we are doing is increasing. And in fact, some years the cadaveric numbers is lower simply because there is less cadaveric donor, but the number of living organ donation has increased over the year and now represent almost 35% of all our transplant. Next slide. And in Toronto, we do believe that living donation help to reduce the mortality of the patient on the waiting list for transplant. Therefore, we offer it to all our adults who are coming forward and is listed on the liver transplant. And we also truly believe that it reduces the mortality on the waiting list, previous slide, but also has a similar outcome than if you get a full graft with disease donation. And that is the study we did here. It's 20 years following up the recipient of grafts that were either from deceased donor, full graft, or living donor. And you can see the red graph is the red line is living donation, blue line is deceased donation, and there has been no difference in terms of the outcome for recipient up to 20 years of follow-up. So therefore, it is safe to have a living donor liver transplantation, even though it means it's a partial graft, because the liver grow back to full size within a period of 3 months. Next slide. So what are the benefit of living organ donation? It's a life-saving transplant that allows to wait less on the waiting list. It allows to return faster to a good health and good quality of life. It helps to have a better long-term outcome, better, and also the quality of these organs are much better because they are coming from someone who is otherwise healthy and is able to donate their graft. And also is also not only good for the recipient, but also from the donors who gain a deep satisfaction from being able to save the life of the people they love. Next. So in order to be a living liver donor in Toronto, someone has to be between the age of 16 to 60 years of age. They have to be in excellent physical and emotional health. They have to have normal functioning liver. They have to have the support of their family, their friends, their primary care. And it's a voluntary act. It's never a pressure on someone to become a living donor. That donor has to feel really the wish that they want to do that. And trust me, the program is built around donor safety as being the number one priority. And we would never put a donor at risk if we have concerns about their health as they are coming forward and they go through the evaluation. Next slide. So the health and safety of our recipient and living donors are, as I mentioned, extremely important in the program here. We follow strict criteria and guidelines for assessing the living donors. You can find them at uhnTransplant.ca. We have a lot of components in the process of assessing a donor to make sure that they are safe throughout the whole process of assessment. And we have two separate teams, one that works with the donors and one that works with the recipient, to try to the best we can to protect privacy and the best interest of both donor and recipient. We try to avoid to mix and match them. Next slide. And what you need to know is that we assess one donor at a time. Donor workup can take around 4 to 6 weeks. And it really takes not more than 8 weeks or 2 months from the time a donor sends their application to the time the donor and recipient, as long as obviously that donor is eligible to donate anatomically from a health flight. It can take up to 2 months for them to go to the OR. Ontario Health or your OHIP will cover the cost of the surgery and the hospital care for both the donor and the recipient. And there is a program that's called Preload program that covers up to 5,000 of living donor expenses. And there are also some coverage eligibility for donors that are out of province or even out of country. Next slide. So how do someone become a donor? They need to fill out a donor health history form. They can find the form at uhnTransplant.ca. They need to submit the form along with their blood type. And they can then wait for the call from our living donor coordinator to reach out to them. And if there is question, you can always call or email livingdonorliver@uhn.ca. And there is also the Center for Living Organ Donation that offers classes to have donor champions, help them, give them advice about how to find a donor, so on and so forth. And don't hesitate to reach out. I think this is my last slide. And I'm going to stop here and ask any question. Does anyone has any question?
Have any questions? Any questions? Wow, it was an amazing talk because everyone's like, I know everything about live donation. Any online questions? I don't see any online questions. Okay, well, that's fantastic. So it was an extremely clear talk. Thank you so much, Nazia.
Thank you.
We'll see you back in Toronto.
Absolutely. Safe travel, okay? Bye-bye.
Do we have Heather online? Heather is our next speaker. Okay, I'll text her. I guess we could also take a very short impromptu break if anyone needs to use the washroom or is good. Or just tech. Oh, sorry. Our next speaker is also, she's from Ottawa and she couldn't make it to Thunder Bay. We have like everyone from around all over Canada. Oh, so Heather said she's here. Um, Heather, are you what are you listed on in the Zoom meeting? Are you like Zoom user or sorry, Heather, we can't seem to find you. Are you able to turn your camera on so we can see you? I'm a little confused.
Check one, two.
I think so. Heather, are you can you hear us? Oh, fantastic.
Hi.
And I don't know if you have slides or not, but if so, you can share your own slides.
I'm
Let us
happy to. Yeah, I do have my own slides.
fantastic.
All
Let us
right.
have any trouble sharing them.
Let me go ahead and do it right now. And sorry for any confusion. I was in like another room with Dr. Mushi.
Yeah, there's a that you were in the kidney side.
And I mean, I'm sure they're lovely and all. I'm sure the kidney folks are fine, but we have a bias.
Fantastic.
All right, let's get this into presentation mode, and then you can tell me if it looks right.
Beautiful.
Does that look right?
Looks perfect.
All right, I love it.
Thank
Cynthia, thanks for inviting me.
Oh, thank you so much, Heather. Maybe you can introduce yourself, but we'll just say that Heather is a fantastic human being.
Oh,
Who helps the Center for Living Organ Donation quite a bit. We're very indebted to her. Heather, take it away.
all right. Well, thanks so much for having me, Dr. Tsien. And so it's my pleasure to come and spend the next, 10 minutes or so with you. So I am well, actually, sorry, I'll tell you a little story and then I'll get to where I'm here. So back in 2016, there was a lovely story in the paper about this little girl who needed a living liver donor. And I realized that I was the same blood type as her and immediately felt drawn to give. And a lot of donors that I know say the same thing, that it was like a snap decision and you just like signed up. You felt very drawn to give. Now, lucky for that little girl, this gentleman who is the dad of one of her school friends, he also applied. And so he became her donor. So I'd already been prepared to give to a stranger. So I thought, well, I don't need to know who it is. So then I told Toronto General, you can just please can I be screened and then match me to whoever needs it the most. And so in this photo, I'm sitting with Kevin Gosling. And if you don't know who he is, that's okay. He is uncle to Ryan Gosling, which is probably a name that many of us recognize. And Kevin was the first non-directed living liver donor at Toronto General. So he was the first person to step forward and say, I want to donate. I don't care who I give to. So please just match me up to whoever needs it the most. So that's Kevin. So I had the really good fortune of becoming a donor. This is what it looked like the morning of transplant day. They give you this lovely heated blanket. And I have to say, I was like nervous the morning of, but also the process had been so thorough. Like this previous slide is all of the tests, all of the conversations, all of the assessments. And I felt like the Toronto General team took so much time, was so thorough in making sure that I was healthy enough, that I was in the right place, that I had supports for recovery. They took the time to talk to my husband, who had a lot of questions. And so they answered every question that we could possibly have. And I was pretty excited to get to this point. This might be one of my absolute favorite pictures on the universe, because that is the picture of my piece of liver leaving Toronto General and going through, I guess it heads through like a tunnel between Toronto General and Sick Kids. So I really love that photo. The morning of, I actually said to Dr. Cottrell, who maybe some of you have talked to, who was my surgeon, and Dr. Cottrell, I said, I want a photo. And Dr. Cottrell said, oh yeah, of course. And like a surgeon, he's like, right, you want the photo of like your insides. It's like, no, 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 I do not want that photo. I am actually quite squeamish. So what I want is the photo of like the bag. The bag for some reason held some symbolism for me, and I absolutely loved it. So for anybody who's thinking about if someone on this, in this conversation has a person who's maybe going to be a living donor, or you're wondering if someone's going to be your living donor, or you're having conversations with someone who's maybe going to be your living donor, just a couple of slides to show what the recovery is like. And can I just say that, like, this looks like a lot of machines, but holy cow, was my recovery like, I just felt like the care was so good. My pain, well, I didn't have pain because it was really well managed. This nurse, Chantal, who I will never forget, was exceptional. And ultimately for me, so this is like day one, the goal is just to get you into the chair. Day two, you do laps. They warn you during the screening process that day two, like 2 days after surgery, might not feel amazing. You might be fairly unhappy like the day, like 2 days later when you have to get up and do laps. I felt great. I think that there's like two things happening. One, the pain management's really good. B, and other donors that I talked to, and I know, like, I think it's safe to say dozens of other donors, and we all say that like the emotional high of being part of saving a life is fairly magnificent. If there are patients who are listening and thinking like they don't want to, you're worried about, someone wanting to do this for you, every donor that I know, and like I said, I think I know dozens, it's safe to say, we all felt like such a draw to do it. And we all talk about the emotional, like the amazing feelings of doing it. And like it's been years since the donation, and I still, it makes me exceptionally happy to think about it. Um, my thought process is it was, I mean, really 2, 3 weeks out of my life. My recovery was pretty good. So 2, 3 weeks out of my life to really give someone else their whole life. And that just was a really wonderful thing that I was pretty grateful to be a part of. This is what day 2 looked like for me. And then I basically just watched Netflix for a bunch of days. I got to leave the hospital on day 6. I took the train back to Ottawa on day 7. That is the lovely porter who was so helpful at Via. And then for a short duration, not like, I mean, I know that recipients have meds for life, but for donors, we do have a number of meds in the beginning, and then it decreases over, I mean, mostly in the first couple of weeks. And then the longest thing that you're on is iron, which is like 3 months, or at least that was the case when I gave. I'm going to say, in all honesty, I did not love the blood thinners. And this was my husband on a daily basis coming to tell me it was the time for like the blood thinner injection, which was not my favorite. So that was for 4 weeks. And but listen, this is a photo taken at 2 weeks. I'm on my way to a family reunion, feeling pretty good. I had not told anyone outside of this car, plus my sister and a couple of friends, that I had done this. And so, believe it or not, I managed to get through the family reunion without like any questions, without anybody noticing anything. I mean, obviously, I got out of like picnic table moving duty because you're not allowed to really lift at that point more than 10 pounds. I was feeling pretty good. Uh, this is probably one of my absolute favorite pictures. And so for anyone in the room who's not a medical professional, which obviously I am not, my friend labeled this photo. And so you actually see like the liver would normally span across your whole abdomen. But in this case, this is my MRI 3 months after, and you can see like where like it got removed, but then the other side gets bigger, right? It grows back in sort of 5 or 6 weeks. And so my friend thought she was hilarious and labeled like a tapeworm and butternut squash and an airbag and all sorts of other things. It was a pretty remarkable experience. Really, really glad to have done it. I don't know who my recipient is, although I've had a couple of anonymous updates from Toronto General. And so I do know that they're doing well, which is, I mean, the whole point and really the most wonderful, wonderful news. And so since donating, I've had the pleasure of getting pretty involved in the transplant community and connecting with plenty of other donors. This photo includes a fellow donor who mentored me, and then some donors that I then got the chance to mentor. So we all connect and support each other, and it's a pretty terrific community, I think it's safe to say. I'm also more than happy, and I maybe it's way we're waiting till the end, but I am more than happy to answer any questions that anyone has. I realize there's like a lot to cover, but really nothing's off limits.
So yeah, we're taking questions now. I
Oh,
don't know
great.
if there's any because I know you have to run at 3:30. So any questions from anyone? No? All good. I'm just gonna check quickly online if there's any questions. June has a question. June, do you want to ask your question? Or you can type it as well if you don't want to say it.
Oh, June says for the previous speaker.
But that's okay. You can still ask the question and we can try to answer. think June is a typer. So I'm so sorry, Heather. I'm just waiting for June to type it
You're
out.
fine. I've got like almost 20 minutes, so more than happy to
Your,
answer any questions.
is your dog available? Can we-
We, we've got two. We've got Sky sleeping, and then I don't know where the puppy is. I don't know where Dory is.
So there is a question. Does MELD score take into account scarred bile ducts? So that's a great question that I can probably answer. So the MELD score is composed of objective measurements. So that's based on your blood work. So when we take your blood work, you'll notice that we always ask for the bilirubin, the INR, the sodium, the creatinine. And so when you have damage to your bile ducts, if that is affecting your bilirubin and your bilirubin goes up, then that will make your MELD score go up. However, there are some diseases that affect the bile ducts, but if the disease is still early, you may not see that rise in bilirubin yet. So you can have a disease that affects the bile ducts like primary biliary cholangitis or primary sclerosing cholangitis, and the bilirubin may still be only like normal is 17, it may still only be 20 or 30 or something like that. But if your disease progresses and then your bilirubin goes up, that will make your MELD score go higher. So hopefully that answers the question. Just checking any other questions. I don't see any in the room. I think I don't see any more online. I did not see your dog yet, Heather, but
She's, hold on, hold on. One of them is here. She's sleeping, but let's just see if I can turn off my background blur. Okay, this is the best angle. So well, there we go. Sky's having a nap.
oh,
And then the puppy, I have a boxer puppy somewhere, but actually it's a little terrifying. It's suspiciously quiet, so I need to go figure out what she's doing.
well, thank you so much, Heather. Thank you as
Thanks,
always for
Dr. Tsien.
being willing. Cynthia, just call me Cynthia. And
Yeah.
thanks so much for being willing to share your lived experience with other people. I'm sure I think it's so, so helpful. Thank you.
Oh, it's always a pleasure, and best of luck to everyone. Take care.
Thanks. Bye. So our next speaker is from Liver Canada. Jennifer, I'm gonna have you come up. And I actually don't know how to advance the slides here. I don't know if there's a
Oh, perfect. Thank you. Oh, okay. I just look around. Not the best with technology, so I'm warning right now. Can I do it? There we go. Well, thank you for having me and inviting Liver Canada to be part of this conversation. I've been so moved. I feel a little like discombobulated by all of the community supports that are in place, the conversation. I feel that there's so much more that we can do, and collectively, if we work together, we can start to build that. But yes, thank you very much. Really, I just wanted to introduce Liver Canada and introduce you to our pre-transplant navigation program. And really, it's all about you not waiting alone, I just have to, what am I doing? It's not working? Hello? Yeah, okay. Sometimes I'm not that close. Sorry. Really, what am I saying? It's all about just making sure that you don't feel alone, that you feel supported. And we want to, like everybody else in these conversations, we want to help to guide people through the entire process from listing for surgery so that you feel, and to even through post-transplant, so you feel supported and not lost in the system. At the beginning of the session, we heard people sort of calling out what their experiences have been. And I believe that we're all here to sort of lift that up and help people. We have a personal navigator at Liver Canada who talks with you on the phone, can work over email, where however you're comfortable, to make sure that they walk with you every step along the way, help coordinating appointments, understanding next steps, and really clear, unbiased information to help make the process less overwhelming. And our promise to everyone is that no matter where you are in Canada, you're not alone. That there, and I think that's been demonstrated today, that there's so many people here to help. Okay, so how do we support patients and families? As I mentioned, we have a personalized navigation system, or navigation system. I sound like you tell I was on an airplane. We have someone that's there to support one-on-one guidance, manage you through your appointments, any transitions, or even those days that you're feeling a little low or just need a little boost, that, you know, you're feeling a little confused what happened, or just a trusted voice to talk to. We have lots of team members and peer support people on hand to listen to your story, to share theirs, and to speak to you in a language and in a way that's most embracing for you. Our living donor campaign support. I've actually had an opportunity to hear about this firsthand from some people, and I was really inspired by their stories and how we help, like, how we saw the template today about how do you build that story. We help. We're there to help you do that, finalize those templates. What's the best way for you to get your information out there, helping you even build, because as my daughter is my tech support, how do you build these networks, and how do I get a Facebook page up and running? That's what I'd say, not me, but the team, who's much more talented, is there to do. And of course, education, plain language education. Sometimes, like what I've heard from some patients is, as soon as the doctor said transplant, I lost everything. Like, that's all my brain could focus on. So we're there to help fill in the gaps, make some connections for you, and also for your family. And I think that that's really important because, as we all know, family is so important, and friends. And I think we heard that earlier with the story, when you're trying to get through the situation, build your confidence, because we know that when you're calm and feel supported, there's much better health outcomes. Oh, gotta do this. Can you guys see okay? Yeah. Okay. So, as I said, we help to fill the gap. What makes us different is we're independent, we're national guidance, we're not tied to any one hospital or institution. We're here to work in partnership. We are continuous support wherever the care moves you across provinces. We were supporting someone who was living in Alberta. She then had to move to Atlantic Canada. So making sure, and without support, so making sure that we were there as a friendly voice, connected her with some of the community that we know in Atlantic Canada, and helped to build that for her so that she felt supported while she was away from her family and friends. I think that, and I think we've all seen this ourselves, that patients who feel more confident and less anxious, families who know how to help and know that we're there to help them, we're finding that that's really where Liver Canada can help to play a role, and more people finding living donors through this system faster. So when people are guided, informed, and believed in, they heal better together. And I think that was, I wanted to repeat that particular line because that was shared with me by someone who was going through the process and wanted to provide some feedback. Oh, here are a few of the other programs that Liver Canada other programs and supports that we have in place. So I think the number one thing I want to say is that's our patient helpline. You can call anytime. There is a person there that will pick up the phone. You can email clf@liver.ca. The most important thing to take away today is that I think what we've felt here today is that there is a community that will help to support you and guide you through this process. And I just wanted to say thank you very much for inviting Liver Canada here today and giving us an opportunity to talk. Thanks. There we go. Oh, I don't know if I should move this on. Oh, sorry. Whoa, that's weird seeing myself 10 feet high. Good. Yeah, thank you. Oh, do you want me to-
So, as I mentioned, my name is Dr. Cynthia Tsien. I'm a transplant hepatologist at the Toronto General Hospital, and I'm going to be talking about liver transplant 101. This is going to be a dialogue because sometimes the medicine is boring. It goes over people's heads. And I'm not sure how much detail people want. So I made this quite a high level overview, but if you want to know more, I can definitely nerd out and give you more info. But just sometimes I see in my clinic, like the patient's eyes are glazing over, and I know they are not retaining anything that I am saying. So please feel free to stop me if you have further questions. So, why would you need a liver transplant? So, unfortunately, due to many different causes, people go from a nice, healthy, smooth, soft liver to a very hard, stiff liver, which is called cirrhosis. And this can be due to many different causes. Unfortunately, many people think automatically of alcohol, which is very stigmatizing because you say, oh, I have cirrhosis, and then people say, oh, it's because you drank too much and you must have done this to yourself, you know. But actually, many, many different things can cause cirrhosis, as we heard another person mention, you know, diseases of the bile ducts, autoimmune disorders, viruses can cause. And all of these things, if you think of cirrhosis like a scar, so if you think like you cut yourself and then there's all this inflammation and healing, and eventually you get this white scar, that's what cirrhosis is. That is basically the scar tissue when you've had injury to your liver from whatever cause. So whatever cause causes that inflammation and healing, and then the scar tissue. And then actually, you know, many people can live with cirrhosis for many years. It's a chronic condition that needs to be monitored, similar to diabetes or high blood pressure. But you don't necessarily need a liver transplant until you start developing symptoms. And these are things like what we call ascites. So that's buildup of water in your abdomen. Okay. Bleeding. So you see here, this is your esophagus. So that's this tube that goes down from your mouth to your stomach. And you can see that there are these large vessels, and these can bleed. These are called varices, they can bleed. And then, unfortunately, something that has a huge impact on people's quality of life is the encephalopathy. So, this is confusion. So people don't know where they don't know who they are. And worst case scenario, people can actually like slip into a coma where you can't wake them up. Another reason that you might need a liver transplant is liver cancer. So ordinarily, if you have cancer, you would have an operation and try to cut the cancer out. But sometimes if your liver is very damaged, cutting out a portion of the liver would actually not leave you with enough functioning liver. So you would need to have the whole liver replaced. So that's another indication for a transplant. And there's actually a lot of other different indications, but I didn't put them down because they're quite rare. But these are sort of some of the main indications for transplantation. And this is where the medical and the patient perspectives kind of vary. I know for patients, this is what matters a lot. This matters a lot to patients. From a physician perspective, what we're thinking is, what are your chances of that you're going to be alive in 10 years, in 1 year, in 1 year, in 5 years? Because as I'm going to mention later on, unfortunately, there's not enough livers for everybody. And so we are kind of in this situation where we try to, you know, prioritize people sickest person first. So if your chance of surviving over the next year is 99%, and there's someone else on the wait list whose chance of living in the next year is 50-50, that person is probably more appropriate to move forward for transplant as opposed to this person with what we call compensated cirrhosis. So that's when you have the cirrhosis, but you haven't had any of these issues yet. So you haven't had any of these problems. So your survival is going to be quite good. So that's why we usually don't kind of preemptively do transplants on people with just compensated cirrhosis. But you can see that all of these things, the fluid, the varices, the encephalopathy, they really reduce your likelihood of survival. And that's why we want to move forward with transplantation. Yeah, for sure. So someone asked about the difference between regular ascites and refractory ascites. So ascites is really a reflection of your liver disease. And sometimes people think of cirrhosis as like just like you have cirrhosis, yes or no. You have decompensation, yes or no. But actually, liver disease is a spectrum. And as you become sicker, there are these changes that happen in your body, like hormonally. What happens is, okay, I'm nerding out. If this goes too much, tell me. But essentially, when your liver is all stiff and hard like this, it actually changes the blood flow in your body. And your liver is like producing all of these hormones that's actually changing where the blood flow goes. So basically, what happens is your kidney starts thinking that you are very, very dry and it needs to hold on as much fluid as possible. Like this because of what's happening with the liver, the kidney gets fooled and starts saying, "Oh my gosh, I need to pull and retain as much water as possible." Otherwise, like, this person's going to be like not have enough circulating volume, faint, like that kind, like not enough blood pressure. And so what happens over time is that you'll notice for people who have fluid in their tummy, like it'll start getting progressively worse and worse because what happens is that the kidney is trying to compensate for the liver. And for a certain amount of time, the kidney can compensate. But then as the liver disease progresses, the kidney can no longer compensate. And so whereas before it kind of made sense for the kidney to hold on to the fluid, like that was a good adaptation. It then, as your disease progresses, it's no longer a good adaptation. And now you're having way too much fluid. And, initially we can treat this issue with water pills. But then as your disease progresses, water pills don't work anymore. And then you start needing to get these, what we call paracentesis, so a drain, which I don't know if people online have had it, but basically, unfortunately, you have to put a needle in the tummy and suck out this fluid. And sometimes when the liver disease is very severe, you have to get that done like every week or two. So when it gets to that point, we call it refractory ascites. And we know the survival is worse because you're further down in that spectrum of where your liver disease is. So even when you go from compensated to decompensated cirrhosis, there's still like more, it can get more severe, even though it's classified as decompensated.
So if you have refractory ascites plus the bleeding varices.
So someone asked about whether these risks are kind of additive. We don't really, I mean, it's a very good question. Usually these things all come together. Usually, if you're having ascites, you're also at higher risk of having varices. You're also at higher risk of having encephalopathy. So, I don't think that we have any data saying that you like add on these risks. But what we know is that once you start developing these decompensating signs, it's a signal that you should be referred for a liver transplant. Because unfortunately, I think sometimes even other physicians are not aware of transplant, like particularly in smaller cities. They may say, oh, okay, you've developed now this, fluid in your tummy. They're like, okay, just start some water pills or we'll do a drain. But they don't realize that that's actually a signal that you need to start looking into a liver transplant because the writing's on the wall that, like, in a while, you're going to get really, like, these are just band-aid solutions. The underlying problem is your liver disease. And if you don't fix that, you're going to, basically you're not going to survive. So I think sometimes it's comes down to what we heard earlier about the care model is, this is why we have these education sessions so you can learn about the liver disease and maybe you can advocate for yourself and say, hey, like, where am I on this scale? And does it make sense to start talking about liver transplant? So what can you expect when you're referred for a liver transplant? So there are transplant centers in across Canada. And not every center has a transplant center. So this is why I put some extra transplant centers because sometimes you could be like referred to a different transplant center. So in Ontario, we have two transplant centers, which are London and Toronto. And I'm actually not sure where people in Thunder Bay go, if they get referred to Toronto or London. You could probably even choose, but um, so people can be referred to one of two centers. And then I know, like, in other places in Ontario, like sometimes people also go to like Quebec. There's basically 7 transplant programs across Canada, and you tend to be in your own province. It's unusual to have 2 transplant centers in one province for liver. Like BC has one transplant center, Alberta has one transplant center, but Ontario and Quebec are the places that have 2 transplant centers, and some places don't have any. So people in Manitoba need to come to Ontario for their transplants. So when you come to the transplant clinic, you will be seen by the doctors to ask, do you need a liver transplant? So where are you on the spectrum of, health? Is the disease advanced enough that you would benefit from a liver transplant? And then the other question is, are you healthy enough for the operation? So when you have a major operation like a liver transplant, we need to make sure that your heart, your lungs, your kidneys are all strong enough to make sure you have a good outcome after transplant. Because, like, heaven forbid, you have a heart attack after surgery or unfortunately, your kidneys get worse after surgery. So that is all part of the assessment. And as you heard today, we also, look at things like social supports because it really sounded from like the patients today that they really got through by having like a lot of support because there's so many challenges for travel, keeping all your medications straight, things like that. So once your evaluation is done, you are then placed on the liver transplant wait list. And I know it is very, very confusing for people to know where you are in that spectrum. Sometimes people come to our clinic thinking they're going to get transplanted the same day. Some people come to the clinic and then they say, okay, now I'm listed, right? And so I always feel bad for the patients. Like, I try to be as clear as possible where you are on the process. So, first, you're assessed. And then once you are listed, you will get a call saying you are listed for a liver transplant. Then you come and see us again. And then the really tough part is then waiting for that liver transplant to occur. And so, as you heard from my colleague, Dr. Selzner, there's two ways of getting a liver transplant. One is through a live donor. And the nice thing about that is it's planned. As you heard today, you can plan for that. You can mark it in your calendar and say, okay, I'm going to take that time off work. I'm going to. Unfortunately, with a deceased donor, you cannot plan. And I think that is the toughest part for people is your life is on hold until that transplant occurs. And so often people ask, where am I on the wait list? The way we do the wait list is basically something called the MELD score. So sodium MELD or MELD 3.0 score. Actually, I'm going to go to the next slide here because this is from our Trillium Gift of Life. So essentially, we have a separate organization that approaches potential donors, speaks to their families, and then calls us and says, okay, we have an organ. And so we have various rules on how livers are allocated. And so this comes from TGLN, which is Trillium Gift of Life Network, who really is the, provincial organization who makes sure that we're following the rules because this really is a gift that donors give for our recipients. And so we need to make sure that we're doing everything the way the province wants it done. So just as a highlight, um, there are two steps to this process. Patients on the wait list are reviewed to determine if they are potential matches to the donor. So when Trillium approaches us with a donor, we get a list of people who are potential matches. And then the order in which they receive the offer is based on their medical profile. And you can go to this website if you want to learn more. And essentially, what we do for matching is we look at the blood type. So for deceased donation, it's a little bit different. We don't cross blood groups. So if you're an A recipient, you would need an A donor. There's very few exceptions for people who have extremely high MELD scores or fulminant liver failure who would die in a few days if they don't get transplanted. And then basically, the other considerations might be things like height and weight. So, for example, if we get a donor who is particularly large, we would not be able to put that into a pediatric recipient, like the liver just wouldn't fit. And sort of the inverse, if we get a very small donor, sometimes we can't put it in someone who's extremely large because that just wouldn't be enough liver for that recipient. And then what we do is we look at the wait list, we look at the medical status, and that is usually there is a different category of liver failure where people, again, like I said, if they don't get a transplant within a day or two, or I would say like within a week, they would die. So these people get prioritized. And then otherwise, patients are prioritized by the MELD score, which, as we discussed, is purely based on your blood work. So bilirubin, INR, sodium, albumin. And then if there is a tie, then it does come down to wing time. So if two people have like the exact same meld score and they're both exactly like appropriate for that donor, then there is like a tie break with the waiting time. So I'm just gonna go back here. So when a liver becomes available, you will receive a call from the transplant coordinator. And that's why it's also hard. Like this could occur at any time of day or night. Um, so the exception is a live donor liver transplant. And then also a cancellation can occur at any time. So it really is like a roller coaster where you have to be healthy and well enough to have surgery when you get that call. And also, the surgery has to go smoothly for you to get the graft. Unfortunately, sometimes the person who's reviewing the donor, they don't see anything wrong with the blood work. They don't see anything wrong with the imaging. But when they actually go and do the operation, then they see that the liver is not appropriate for donation and then they have to abort. So that's why sometimes you get called in and even like you think, okay, I've been called in for surgery. Like sometimes it gets canceled, like even right up to the moment where you would expect to go for surgery because there's an unexpected issue with the donor. So it's very, very unpredictable. But I think the bottom line is the surgeons do not want to do a donor that would not give you a good outcome. Because if they proceed with a donor that is not suitable, there's a risk that the liver does not function, and then you have to have a retransplant. So that's why they want to be careful and make sure if they're going to do the liver transplant, then it needs to be appropriate. So if you're called in for your transplant, the surgery lasts for about 5 to 8 hours. And we say the average hospital stay is 10 to 14 days, but I'm going to mention later some exercises that people can do because it is important. The healthier you are going into your surgery, the better you're going to do afterwards. And there is a risk of complications. So, um, you may need blood products during the surgery. You may need to go on a bypass machine. You may need to have dialysis. Afterwards, you may need an abdominal drainage tube. You may need a stent. So there is a risk of complications afterwards. If you look at the donor, I hope people are not squeamish. I think this is not too squeamish, but sometimes people don't like to see. So essentially, what they do in a full deceased donor liver transplant is they will make these like cuts to remove your liver and then put in the new donor liver. And you see that when they're sewing together all like, I mean, this makes it look very easy, right? Like it's very neat. There's no bleeding, like it's perfect views. But in reality, these arteries, these bile ducts are very, very tiny. And so sometimes you can get complications where we call them an anastomosis when we suture it from the recipient to the donor. If these are too tight, sometimes there's no blood flow going to the liver, and that's a problem. And then you need a retransplant. And sometimes if these bile ducts are too tight, if they sew it too tight, that's where you might need like a stent being inserted. So these are some of the complications that are from like surgical complications. And then I didn't really talk about it, but you also need to start immunosuppressive drugs after the transplant. And those medications are very, very important because if you don't take them, there's a high risk that you reject your new liver and then you can't live without a liver. So that's why we talk quite a bit about, drug coverage and, making sure you adhere to your medication regimen because if you miss your medications and reject that, then that can really impact your long-term survival. You're encouraged to sit up and walk as soon as you're able. there will be too many people visiting you. You will be like, who are the 40 million people who are seeing me? Again, this is why I loved, the care talk, write things down. You're going to see nurses, discharge nurses, pharmacists, outpatient. You're going to be like, who is everybody? And like the worst is like even the doctors, we share the pre-listed clinic. So you're going to like see these rotating doctors. And then afterwards, you're going to have one doctor taking care of you. But upon discharge, you will have a schedule that tells you when you need to come to the hospital for blood tests and clinic visits. And so if you're from out of town, you may need to stay in Toronto for up to 1 month post-transplant because if there are any surgical complications, the surgeons are in Toronto, not in, these other hospitals. So if you need an emergency surgery related to the liver transplant, it's better if you're in the area because it's not like we don't want to try to have to transport you down like when you're 2 weeks post-transplant. So that's another issue that Sasha usually tries to help our patients with trying to navigate, it's unfortunate in Canada, we're such a giant country and the resources are kind of it in I mean, you go to some place like the UK and it's like, twice the 3 times the population in like, in one province. And so, the reason we kind of harp a lot on live donation is because we just don't have enough livers for everybody. So if you kind of bring your own liver, then it is, less stressful because you don't have to play that waiting game where you don't know when you're going to be transplanted. And I know a lot of patients say, I don't have a live donor. So this is why we try to do these sessions to help people as much as possible. But we totally understand some people just, they can't find a live donor or it doesn't work out. So people are able to have deceased donation. But, unfortunately, every year, even though we're, doing more and more transplants, the number of people and indications goes up as well. So there's always this gap between, the transplants we do and the people who need them. So I want to leave you with this fantastic website. I think, you may have heard of this already because I always tell the patients who come to clinic, I always point out this website, which was developed by a very good friend and colleague in Alberta. And I think this is really important because you cannot control your MELD score. You cannot control the donor who comes. You can't control your height and weight, you can't control when the next person who's going to decide to donate. What can you do? All you can do is keep yourself fit and healthy for surgery so that when that call comes, you're ready to go and there will not be any issues with proceeding with surgery. So and I think also what really helps your mental state is keeping fit and healthy. Like we know the quality of life is terrible. If you're having confusion, if you're having ascites, you're becoming more frail, it's hard to walk, it's hard to take care of yourself. Like these are all very, very challenging things. And so I think we don't really put enough emphasis on diet and exercise because we know that exercise will help prevent frailty, but also is good for your mental health. So they have an online exercise program, which obviously, you need to be careful. So that's why they have this, kind of warning sign to talk to your healthcare team. But they have these fantastic videos on the website that look at muscle strengthening because we know that patients with liver disease should be doing aerobic activity, so like going for walks. We know that people should be doing muscle strengthening exercises. And so these are some fantastic exercises that you can do carefully under medical supervision if required. So you can watch these videos and do these exercises. And I think it's really, really important because again, frailty is really associated with post-transplant outcomes. And so, while you're waiting, we just want to make sure that you are still, strong enough to undergo surgery. And then the last thing I want to highlight is really this nutrition and cirrhosis guide, which again is another thing about, everyone wants to eat healthy. Everyone wants to know, like, what are the things I should and shouldn't be eating. And so this is a fantastic guide. It's actually a PDF that you can download from the website, and it goes over things like being on a low salt diet. How do you increase the protein in your diet? Should you be eating every few hours to try to maintain your muscle mass? And then they have specific recipes. And then I was so impressed. Like, I think this is new since I last looked at the video. They even have how-to videos for recipes because I mean, I'm the same way. I don't know what to eat every day. I'm like, what the heck do I eat? So these recipes can help people decide, how do you eat low salt? So I guess there's low salt macaroni and cheese that you can make, but also, high in protein. And then I'm really sorry, I wasn't able to get a recipient to come talk to you guys today, but I do want to offer you some hope that there is another side, that it's a very long and difficult journey, but the goal is that on the other side of your transplant is many years of good health. And I wanted to highlight something called the World Transplant Games, where people who have undergone liver transplant go and compete. Actually, one of my patients who was transplanted when he was like 19 actually went recently and played in the transplant games. So there is a hope. There is hope afterwards. It is very, very difficult going through it. The uncertainty, my heart goes out to people waiting for liver transplant because I know the uncertainty is so, so tough. But the goal is, again, to get you to a normal, healthy, functioning state post-transplant. And that's why we really want to help you as much as we can with information, education, and if there's any questions, please feel free.
Actually, two questions. The first one is, I think I was talking to Dr. Selson in the last video. And she said then, or that even if for living donation, the chances of a person being compatible are only like 1 in 3. And I'm wondering if that stat is different for living donors that are very, very close relatives. Like, for instance, with me, our son. I'm just wondering if the stat changes slightly with that.
So I'm just going to repeat just in case people didn't hear. So unfortunately, sometimes donors are not a match for the recipient. And Dr. Selzner mentioned that 1 in 3 people are usually a match. So 2 out of 3 donors may not be a match. That's usually, oh, I'm so sorry. She said 1 in 3 is a match. Yeah, 1 in 3 is a match, and 2 out of 3 are not a match. You're saying it's the opposite? 2 out of 3 are a match?
I don't have encephalopathy yet.
Yeah, we're having some disagreement here. You know what? Let's just say, I don't think the number really matters, but I think basically what you're asking is what makes a person a match. And if you're a family member, are you more likely to match? So usually when they are assessing donors, they look at the blood group, and then what they do is they are looking at the anatomy. So usually what prevents someone from being a match is the number of bile ducts and the number of arteries. And do they match with your bile ducts and arteries? And so usually that would not be related to like if it's like a friend versus a family member versus an anonymous donor, that doesn't change. It's more the anatomy of like how many bile ducts do you have, how many bile ducts do they have, and would that be like compatible?
Okay. My other question had to do with diet. I noticed on that one slide that you presented, you mentioned mac and cheese, but that's high in carbs, and I thought I was supposed to try to stay away from the carbs. Um,
I think that is a recipe. Like those are recipes, and I think what they're trying to do is like have those forbidden foods and like a recipe in a way that is compatible with the diet. You know what I mean? Like macaroni and cheese is usually very high in sodium, like you said, very high in carbs. But then they try to like change the recipe so it's like a low salt, high protein type of recipe. So that's why I think it's helpful because I mean, frankly, the biggest complaint I always hear is like I hate the food. It's so tasteless. I'm told I have to eat all the time, but I don't want to eat because, I can't eat any salt. So like they try to really provide recipes that don't make you feel deprived, but like have those like changes so that they're compatible with this low salt, high protein diet.
I find in my case too that my appetite is down a lot, and a lot of it has to do with ascites because I just had a drain 2 days ago actually. Um, it seems that things just don't flow right with the ascites. Um, so
That is very, very common. And so that's why this is why they try to put together these tips and tricks to help you eat, because we all know that patients like again, there's like a certain number of calories that you should be eating every day. There's a certain amount of protein that you should be eating every day. It's not that carbs are bad for you, but the idea is that you need to prioritize protein. And so if you can't eat very much because your appetite is so small, we'd rather you be eating protein rather than carbohydrates. But it's not that like, carbohydrates are gonna like, hurt you per se, but it's more that in order to maintain your muscle, you need to eat a certain amount of protein. And it can be very difficult for patients with cirrhosis, with ascites, to eat enough protein. So that's why I really like the website. It gives all sorts of like ideas on how to add protein to your diet. And, I also advocate for like protein supplements. Like, there's nothing wrong with adding protein powders to your food so that you can get enough protein during the day.
drinks like the pure protein.
Yeah, so protein drinks. So protein drinks, we usually recommend like Ensure or Boost. The ones that like weightlifters use to like kind of bulk up, you just have to be a little bit careful because sometimes they can cause like liver enzyme elevation. So usually we recommend the ones like Boost, Ensure. The only other thing you have to worry about though is that sometimes they're high in sodium. So you really have to check the salt content of them because it can be considerable. So that's why I usually recommend there's like this I think it's called like Benoprotein, something like that. Like there's usually protein powders that are done by like these like Nestle that actually like oncology patients take, like like cancer patients to try to bulk up. So you can add those protein powders to your food. So like usually dietitians will be able to like direct you to like the best protein powder to take.
What do you think about? You've heard of a shake called Premier Plus?
Oh, Premier Plus. Yes, yes. I believe, yes, I've heard of that and I believe that's a good source of protein. Yes. Yes. You just need to be, again, you just need to look at your sodium content. But if people are keeping track of their total salt content, then if you're following that 1,500 milligrams per day, then there's no reason why not to add it. And like you said, high in protein. So that's great.
The other question I had is, how much of a donor's liver do they take?
So for the donor, they take around like 60%, depending on the type of, yeah, like 60 to 70%, depending on what type of surgery they do. You keep 30 to 40%, and both of them regenerate. Like within a month, they grow back. They have to, that's the other reason why someone might not be a suitable donor. They have to do these calculations to see how much liver they're taking from the donor and if that would be enough for the recipient. So that also sometimes why people are not a match. Any other questions? Yes.
Thank you. I work in a community health center with a lot of vulnerable people who should have been probably referred for liver transplant. However, I think a big deterrent is the fact that they're going to have to move for a considerable portion of time to Toronto. And just curious if you have any advice or recommendations for these clients because they've almost given up hope because of this. And it's like they don't even want to consider it anymore because it's just kind of off the table. But just curious if like maybe social work wise, like
I know, I'm looking at Sasha here. Do you want to come up and maybe answer that question? I mean, also, like, it's really basically you need to come down for your initial assessment. Come every 6 months for like while you're waiting for a transplant. And then usually we say once you obviously you have to be able to come for your surgery. And then we say 1 month post-transplant. But sometimes if people are there for 2 weeks, you know what I mean? Then like they've already done half of that. And so they might only be there for another week or two. Or, it's some people, are there for a month, so then they're kind of ready to go home afterwards. I think that, I agree with you. One big problem is the support person because the support person has to come. And then what do they do for a month? We actually have a lot of patients coming in from Manitoba. So I don't know if you want to comment, Sasha, on what the Manitoba, like the Winnipeg patients do. Sorry, Sasha, do you mind just coming, just because there's no, like, no one will be able to hear. Sorry. Just so we have the microphone. Thank you.
So from Manitoba and from Ontario, it's very similar issues. Other than the flight to come from Manitoba to Ontario, they still have to pay. Manitoba has like a program, the Lions Foundation, but it's like around 5, 6. It's not a lot of money. But what we try to do with our patients, regardless of the province, is getting them connected to resources early as possible and letting them know things exist, right? Like Hope Air can help with flights to come out for the patient and their family member for all of their medical appointments. They can get pre-approved and prepaid for, and seeing what kind of social assistance programs they are eligible for. And so I think for a lot of the patients, they might not know these programs exist. I tell them to at least come see the doctors for your first appointment, see how things are going, and then take it step by step. But also, it is the support person. I think that's the bigger piece. They're taking time off of work, and a lot of people aren't paying in, depending on the type of job, if they're not paying into like employment insurance and things like that. And that's where we try to look into their family network. It doesn't need to be the same support person. And I think it's just so scary for them. So sitting with them in that and trying to problem solve, and sometimes that takes many, many appointments to get to it. And like social work does everything virtually. So that's the nice part. They're not having to come out to work on those pieces. Oh, good.
Thank you.
I had 6 kids 30 years ago, and I was in the hospital with our baby, and my husband was stayed at the Toronto General Residence. Do they still have that? It was like a dorm.
We have the PM, like the Princess Margaret Lodge, but that's for oncology. That's probably before. And it was free?
Dorm kind of situation.
And was it free? I feel like that's the lodge, because the lodge is kind of like, it's a lodge, right? Yeah. Yeah, I think that's one of the, yeah. Well, for oncology patients, it's around, but I think that's like the barrier, right? Like some organs have different, like for lung, like there's different things for different organs.
She's just a patient in the hospital, but
Mhm.
he could stay there for the full time.
Yeah, like we have discounts with like some of our hotels, but I think for people who are already coming from a low income or I think everybody at this point, like some more than others, I think with the economy, I think the discount is not making or breaking the decision. So it's um a lot of the patients are doing like GoFundMe pages, which, we're not supposed to promote, but that's what people are doing because they kind of have to do what they need to do. Um, so lots of times it's having those like helping them have uncomfortable conversations with their family about or friends. How can we kind of gather um, more money? I know the kidney social worker in Thunder Bay estimates like tells people to save up to $10,000 to come out. Um, that's a lot, and I think it's encouraging people to take it one step at a time, which is easy for us to say as staff. But
Any other questions?
is there anything online?
Yes.
You mind reading it out loud, Sasha? You want just reading it?
I could. It says, what is the reason for a patient on a waiting list, but needing to have him? I think you should. It's like a medical term and in health, we a special, but there have to get different and therapy
Okay, so the question online is about getting therapy while waiting for a liver transplant. I think that's what the question is. Like immunotherapy? It might be about around liver cancer because sometimes people with liver cancer need to get treatment while they're waiting for liver transplant. I'm going to guess that's what that question is about. So basically, for patients who are waiting for a transplant um, for liver cancer, um, because the cancer needs to come out completely, they need to get treatment so it doesn't spread. Usually for liver cancer, it's a wait time of 6 to 12 months. And during that time, if it's a large or aggressive cancer, it needs treatment. Otherwise, it may spread outside of the liver. And if any cancer goes outside of the liver, then transplant is no longer a reasonable option because we're taking out the liver, but we wouldn't be taking out any like spread to the lungs or anything like that. So that's why it's important to get the cancer treated while you're waiting for a transplant. And also, we know that there is a risk of the cancer coming back after transplant. It's quite low, but it's still around 10 to 15%. And that's related to, these little tiny like tumor cells that we might not be seeing with our naked eye on the imaging, but might be like floating around in the body. So that's another reason to try to get the cancer treated prior to transplant so that you can get rid of all those cancer cells so that they don't come back after transplant. Hopefully that answered that question. Yeah, of course. No problem. No problem.
Just regarding immunization.
Yes.
Now he's on the transplant list now.
Yes.
Our son is started his testing. He's had his flu vaccine, his COVID vaccine. But the RSV vaccine, I noticed that in the Ontario government only covers it for people post-transplant.
Yes.
Would you recommend that he have it prior?
So to be very frank, I think, oh yes. So for the RSV vaccine, we're mostly recommending it for patients post-transplant who are immunosuppressed. Patients with cirrhosis are immunosuppressed. So I think that it's not a bad idea to do it, but I'm not sure if it's covered because you may have to pay. That's the issue.
I just thought, I think it would be better to have it now rather than.
Yes. I mean, we know that like for patients who can't afford it, I'm not like, oh, forego something else so you can pay for the RSV vaccine. Like we know it's the people most at risk are actually post lung transplant patients. So I would say that there is a risk, but like I don't think I don't think you need to like be like I'm not paying for this so I can pay for this, you know? Like I think the risk is low enough that you could do it before if you have the extra money or you could do it afterwards. But I think regardless, in this season, we should probably all be washing our hands and like avoiding other people wearing masks if necessary. I agree, get your flu vaccine, get your COVID vaccine, get any other questions?
I was wondering, are we, they might not let them to act clinic, so you check with them.
Yeah, I did look online and I did talk to a family doctor and he said, yeah, he doesn't meet the criteria until he's had his transplant and then he'd be eligible. He's immunocompromised now, so why not? That's the government.
Exactly, exactly. And any other online questions or okay. Okay, well, thank you so much for coming out. Thank you. And we'll be sticking around for a little bit if you have any more questions. So, and thanks to the online people. It was nice to have you attend. Thanks, everyone. Oh yeah, that was the other thing. Fill out the online survey if you enjoyed the presentations. I actually have to mention that this was funded by the Royal College of Physicians and Surgeons of Canada. And so like in order to get additional funding, if you guys can please fill out the survey so that we can demonstrate to them that this is very, very necessary to do these education sessions. Thank you. Thanks. I think they did one in Winnipeg, but then COVID hit and we stopped doing them. And then when we started it up again, we wanted to really focus on places where people are disadvantaged for transplant. So that's why we wanted to come to Thunder Bay because there is like a large indigenous population. There is like a lot of barriers to transplant. And then we also did it in Scarborough and Toronto because like there's a lot of data showing that most people who go for live donor liver transplant are Caucasian. And so we really wanted to target like the Afro-Caribbean Black community, Asian community, indigenous community, because why, will people not go and do blood donation? It's like so much better in that you have an endpoint. Otherwise it's terrible. Yeah. You're waiting a year, 2 years, you never know.
The financial barrier is huge, right?
Yeah.
Huge for a lot of people.
Yeah. Taking 3 months off of work to go. Yeah. But thanks very much for coming out.
He was planning on coming to Benny.
Oh, yeah. We were wondering. We were kind of debating evening versus daytime.
Yeah.
And then some people told us no, it should be daytime. So, but we were really flip-flopping on it should be. So maybe we'll come back and do an evening session.
By that time, he'll be all done.
Exactly. Thank you.